Hey guys, let's talk a bit about block one. Congratulations on getting through the first block. Let's start with, does this patient belong in your clinic? So I've linked here some calculators. The first one's really not a calculator, but a good place to bookmark on your computers, since most of us are probably using EMR, the Ottawa Ankle Foot Rules and Well Score for DVT. I can't ever remember every single item of these, so I just have these bookmarked on my computer. Other considerations for does this person belong in your clinic that we didn't really talk about so much this week, but I'd like to just mention to you is diabetes. Folks are probably underscreened for foot sensation for those with diabetes. So look up how to do that. Order some of those monofilaments. And it's something that you just don't want to miss and will cost the healthcare system and your patient a lot down the road. So go ahead and be that primary care provider for them and educate them well on their foot considerations. Also, stress fracture. This may be something that you do end up treating, but you do want to have medical management of a stress fracture. It's not something that you would want to just educate them on pain neuroscience education and have them continue to run. And then some vascular considerations. Peripheral artery disease, venous insufficiency. Make sure that you know how to differentiate perhaps something coming from lumbar spine or an issue in gastroc between peripheral arterial disease with measuring ankle brachial index and our venous insufficiency. So just make sure that you're looking at that. As far as other screening goes, we do need to make sure with every patient that is in front of you for lower extremity complaints that you're screening out the lumbar spine. What does screening out of the lumbar spine mean? Well, it's probably based on your index of suspicion. At the very least active range of motion, I would say that the lumbar spine is not ruled out completely unless you perform overpressure and repeated movements in the lumbar spine. Also looking at neurodynamics of the lower extremity. We didn't talk about as much this week. We will talk about that in other conditions. But making sure that you're including that in your examination. And then for any symptoms in the lower extremity that are beyond the gluteal fold, you need to be doing a neurological exam. That's dermatomes, myotomes, and muscle stretch reflexes. Talking about regional interdependence this week, I think that we all have a very good grasp on the musculoskeletal, the mechanical, biomechanical aspect of regional interdependence on how, especially in the lower extremity, how one joint can affect another joint. If something's going on in the hip, there's significant weakness or non-use of gluteal abductors, how that could down the chain create some collapse of the arch. However, we need to be also considering biopsychosocial and neurophysiological effects into our regional interdependence. Now, this ties in our biopsychosocial in with the talk we had this week on pain neuroscience education. Just like any other intervention that you provide, there's going to be folks who require more or less of any intervention, right? So if you think about manual therapy, there may be some populations that need a lot of manual therapy. There may be more other populations that require more therapeutic exercise. And there's going to be populations that require more pain neuroscience education. To some degree, I feel like we should be educating patients on pain, every patient. And just like the example I just gave, there are going to be some people who need a lot more pain neuroscience education because you feel like their presentation is less driven by nociceptive factors in the periphery, and they're more driven by central processes or central abnormal processes. However, we can provide pain neuroscience education in small little doses. And we can probably do our part, even though you wouldn't maybe term it pain neuroscience education, not doing harm with our words. So, avoiding pathoanatomical terms. And that, in my mind, falls under that broad category of pain neuroscience education, in that we're not doing harm with our words. As far as outcome measures, most of you guys are using the lower extremity functional scale or photo. Those are great self-reported outcomes to use. Make sure you know what the MCID is there so you can tell whether you're making a significant change. And then using functional outcomes as well. Things that are more objective, the timed up and go, Berg balance, 30-second sit to stand, or hop test. And all of this would be dependent on your patient. If it's a high-functioning athlete, your tug is not going to be so helpful. If it's a low-functioning hip OA patient with hip OA, then your hop test would probably be not useful in that situation, right? So that all makes sense to us intuitively. All right, for next block, your subjective examination patient case is due today, Monday. Be sure to check back on your discussion boards each day. Your initial post is due Sunday, and I notice many of you are not coming back and responding to questions that are posed to you until Wednesday or so. So try to get those responses in early. A lot of the learning happens from you watching the videos, you doing research on your own, and forming your reflection post. But a ton of the learning also occurs with that dialogue that happens between you and the fellows in training or TAs or faculty or other members of your group. So make sure that you're coming back to do that. All right, we'll see you on the boards.